Okay, hi everyone. Thanks again for inviting me. It's actually really nice to be invited back to this week and conference, given that I gave a similar talk on the initial setup of the trial, and now I get to report a little bit on progress. So great news, and I've been very busy for the year, as has my co-chief investigator, Professor Griffin. So this is a joint project, and I'm sure he'd be happy to help me out with questions if there are lots. So what are we talking about? We're talking about patients who go into a lower limb plaster cast or a boot or a fixed rigid splint following a lower limb injury who are discharged from the emergency department. And unfortunately, over the last 20 years, we've seen multiple fairly tragic cases of VTE resulting in significant morbidity or death as a result following this kind of injury and this degree of immobilization. And these are particularly poignant cases that get a lot of media attention, often because it's a very fit and healthy group with relatively limited comorbidity. And unfortunately, because previously there was very little understanding of the additional VTE risk that came with this kind of immobilization. So people didn't even know it was a potential risk. And then all of a sudden found themselves particularly unwell, or their relatives particularly unwell. So nasty things to read, and unfortunately, things that have continued over time. Those are anecdotal examples, but of course we can look at the detailed evidence and the trials that have been performed in this area, looking at those patients who go into lower limb immobilization and aren't prescribed any degree of thromboprophylaxis, so are managed in a controlled type fashion. And we could look at their VTE event rates over 90-day outcomes. And we see here from multiple studies that the risk probably does sit around 2 to 3%. So not huge, not particularly high, but significant in terms of its clinical outcome and its ongoing persistence over, what I think is well over 20 years there. And when you compare that risk to a baseline for a similar patient group, such as those with a hand injury or a wrist injury attending the emergency department and sent home in a plaster cast to their upper limb, what you find is that lower limb immobilization increases the risk of subsequent VTE by a factor of about 6. So it's a huge increase in the baseline relative risk. And of course, we have to put this in the context of the population, which we estimate is around 70,000 patients per year in the NHS going into immobilization. So 3% of that is in excess of 1,500 VTE events. And what can we do about that? Well, we do know from trial data that the use of parenteral anticoagulation at prophylactic dose using low molecular heparin probably does reduce the risk of VTE in this group by about 50%. And that's in keeping with the use in hospitalized patients and other groups, that it's an attributable halving of the relative risk at baseline for the population. And this is an example from a recent systematic review and network meta-analysis that summarizes all of the literature on the topic and highlights with the thick black lines those agents that have been compared directly against each other in trial evidence, and the dotted lines showing which potential interventions have been compared against each other subjectively, I suppose, without direct comparison in trials. And you can take from this that the weight of the evidence, so low molecular weight heparin versus control, has been fairly extensively looked at in over 4,000 patients. But DOACs, aspirin, fondaparinux, relatively understudied in quite small patient groups and relatively understudied in terms of directly comparing one against the other. So still lots of questions in this area and lots of uncertainty. Now, if we know that this is a problem and we know that there is an intervention that will work, I suppose the next question that usually follows on is, well, what's the cost of that intervention and who should we give it to and how long should we prescribe it for, and how can we trade off the best benefit to risk profile for our patients? And we did quite a lot of work on this, looking at decision analysis modeling that I think Xavier mentioned in his last presentation, which is essentially health economics study of a particular intervention and taking all potential outcomes from that patient group and following them through to a period of time where you can attribute a cost to the NHS and then looking at what type of strategy might result in the best clinical effectiveness for the best cost ratio. And this is an example of us using NICE's rules, who set a clear threshold for what they consider to be cost effectiveness in terms of the price per quality adjusted life year. And when we looked at this in detail through an NIHR-funded project, taking us a good couple of years, we found that actually giving thromboprophylaxis to everyone in this patient group would probably meet NICE's definition of cost effectiveness, because we would get quality adjusted life years at a cost of less than £20,000. But what we also found is that if you use a risk score or a model that helps accurately identify those patients who are at higher risk, then as you kind of dip down through that score, what you probably maintain the health outcomes, but your costs start to reduce. And there is a sweet spot represented by these crosses of a particular cost threshold and clinical threshold for prescribing, where we think it will be maximally cost effective to use thromboprophylaxis in this patient group. And at the same time that we were doing this work, we also worked with NICE to try and look at their quality statements for VTE and reflect on their guidance. And we saw this new quality marker arise in 2021, so a couple of years ago, suggesting that we should probably be looking a bit harder at this population. We should be performing some form of risk assessment, and we should be using that to guide our prescribing of thromboprophylaxis. But there's lots of uncertainty here, because we're talking about risk in a fairly dichotomous fashion, so high risk and low risk, which is often the kind of direction that clinicians lean in. But actually, that's probably not accurate or representative of this population. And there probably is a super low risk group, a lower risk, a medium, a high, a particularly high risk group. And actually, what we've found by studying this over the last 5 to 6 years is that incremental risk scores perhaps can be a bit cleverer than that dichotomy of high and low risk. And we've seen lots of publications in the last couple of years in particular that have taken the whole cohort overall and reported very low VT event rates when you take out those patients with particularly high risk characteristics such as active cancer or previous VTE, and you focus on the majority of healthy individuals. And those studies are kind of inclining towards prescribing less prophylaxis, which might be absolutely the way forwards if you can accurately identify those particularly high-risk individuals. We've also seen some work from the Netherlands suggesting that actually, even in those individuals that you identify as high risk, perhaps our routine dosing of pharmacological thromboprophylaxis may not be enough, because we still do see event rates of 1.5 to 2% in those individuals at times. And so perhaps we need to look at intermediate dosing or higher dosing levels for particularly high levels of risk stratification. So lots of ongoing questions here. But we've seen a bit of progress. So we've seen a couple of risk scores published and derived in methodologically robust ways in the last few years. And we've seen a really nice validation study of the TripCast score, probably the best derived and the best validated study to date in this area, which was published in The Lancet last year, looking at their score and how it performs when you introduce it to a population that gets a fairly universal approach to thromboprophylaxis, as they have done previously in France and Belgium. And this is just a snapshot of their results, but in a very robust way. They introduced clusters of TripCast use within their population, studied over 2,000 patients, and found that by using a score that was derived and validated in a scientifically robust manner, they could identify a high-risk proportion, they could reduce their broad anticoagulant prescribing, and they could really lower their VTE event rates in that population. So good data and worth thinking about using. So following on from this work and following on from the TripCast score publication, the NIHR has worked with authors and experts in the field to commission a call, just like they have done with the direct trial we heard about previously, seeking to really tackle some of the uncertainty in this group. And their commission call was quite interesting to those of us in the field, because they suggested that we really know so little about this group, and the evidence to date is old and perhaps not done to the standards that we would adhere to today. So they asked the academic community to look at a population with lower limb immobilization, both the low risk and the high risk individuals, and think about different types of thromboprophylaxis and how acceptable they might be to patients, what impact they might have on VT event rates, and how people might progress over the lifespan of study. And we put forward a call for this, a bid that was received favorably, and so we've been funded to deliver this trial in 2023. We spent a year designing and refining and recruiting expressions of interest, and we actually started recruitment in around this time last year. So we've been actively recruiting for 12 months. And this is our design. So we're looking at adults placed in temporary lower limb immobilization as a result of injury. We're going to use the TripCAS score to allocate them to a low-risk strata or a high-risk strata. And the high-risk strata enter into what's called a non-inferiority trial. So again, as per Xavier's previous design for directs, we don't really think we need to prove that DOACs are better than low molecular weight heparin, which is the current recommendation by NICE. We just need to prove that they are no worse than our current standard. And with the low-risk strata, we are looking at a superiority design. So current NHS practice, we feel, is to not prescribe any prophylaxis to those individuals who are identified as low risk, but the NIHR want us to test whether giving those individuals drug may decrease overall event rates, may be acceptable to patients, and may provide overall benefit. Our study activities are fairly routine, but it's a very light touch trial. So we're signing people up by email. And then after some baseline data and initial randomization strata, we're then focusing mainly on patient-completed surveys that run at 7 days up to 42 days. And we're asking questions about ongoing immobilization, compliance with drug use, and asking for evidence of any complications, such as representation to hospital or downstream NHS resource use. And then we also are completing a 90-day follow-up, which is more research team-led, thinking about potential complications and thinking about overall NHS resource use. I could talk more about the study, but we've got a lovely set of patient videos that we've invested heavily in that address most of the design of the study, how it appeals to patients, how people flow through the study, how people can deal with any issues that arise, and they're all hosted at the TiLLI.digitrial internet address just below. I'd really encourage you to have a look at these. They're really nice 2.5-minute videos, but also they take you through the kind of flow of the study and they highlight the risks as we understand them currently in a way that's been designed by our patient group working with the video producers for the DigiTrial company. So it's a really nice piece of work that has helped us have high recruitment rates for the study. And where are we up to? So we've had a kind of ascending trajectory of recruiting sites to be involved in the study, and I think we're up to about 16 sites now that are actively screening and recruiting for the study, with the hope that we'll be up to 18 by the end of the year, looking to expand to 30 for the duration of the full trial. And for TiLLI High, we found quite a high conversion rate. So for most patients that we approach and say, we would usually give you injections for this, but would you like to take part in a trial where you might get randomized to receive tablets instead? We've had an uptake of over 80% of those patients that we approach. And I got some updated numbers on this yesterday, and I think we've recruited just over 300 patients to TiLLI High now, which is a really great start for the pilot. Places us in the amber criteria, so not quite as perfect as we want it to be by NIHR standards, but we think good enough to perhaps expand and develop and continue. And we've just had a substantial amendment approved for the study as well that will make it a little bit easier to recruit patients within the trial logistics. So we're hoping that will help us get back up to green. For TiLLI Low, we are finding it difficult. So when we're approaching patients to say, we would usually just give you advice about hydration and VTE avoidance measures here, but we are running a trial where we're testing pharmacotherapy for prevention of VTE downstream. Would you like to participate? We're finding a lot of people are uncomfortable with the idea of using medications for what could be a 42-day period when they might be fine without them. We're finding some people get concerned about the potential costs of getting prescriptions from a pharmacy when they might not use medications. And lots of people are perhaps struggling a little bit to understand the research question here, which is interesting. And it's why we do pilots. We test a hypothesis and we see what happens, and we try and refine and adjust as best we can to see if we can move things forwards. So we're going to reconvene at the end of our pilot period, have a good look at this data and see how we want to progress this arm of the study. There's other research trials looking at this that are happening in Europe as well. So we're working with colleagues to standardize our data collection points and our outcomes on this, in particular working with colleagues in France and Belgium, who are doing a very similar study to TiLLI High called RiverCast, where they are again separating patients into a high-risk category using the TripCAS score. and then randomizing those patients to receive either low molecular weight heparins, which is their usual standard of care, or rivaroxaban, a prophylactic dose for the duration of immobilization. There's also a Swedish trial looking at IPC devices in this patient population, but I have to confess, I'm not entirely sure how they're applying them underneath a plaster cast or in an air cast boot. So I don't know how well that's recruiting, and I don't know how things are unfolding. There's lots of fringe benefits from a study like this, which is great to realise over the lifespan. So within our first year, we've worked with Thrombosis UK to develop a bespoke patient information leaflet that's available on the Thrombosis UK website. And we find that this is facilitating people to have a lot more conversations with patients about the issue, highlight the potential risks, and highlight what people can do themselves to try and avoid it. And this is a key part of the reason to do research in this type of patient group. You know, we know from lots of the tragic incidents presented at the start of this 15 minutes that some of the issues in this patient group is because they just didn't know when they were put into plaster that VTE would be a risk for them. So when their leg got painful and got swollen, they assumed it was a complication of their fracture, another different issue that needed immediate treatment. So having these conversations is a really powerful, positive thing that's coming from the trial. And we're also spending lots of our time as we recruit patients in having these conversations within clinical circles as well. So Xavier and Beverly and I have been hard at work highlighting this issue in hematology journals, in orthopedic journals, and in emergency medicine journals. And actually, I've been really pleased by how positively that's been received. There's been lots of good responses to these articles. There's been lots of positive questions, lots of interest in the situation, and lots of desire to get involved in the study that will show us what the best way to approach this in an evidence-based fashion is. And that's exactly what you want to see when you write an opinion article. And in the last few minutes, maybe I'll just tackle some of the questions proactively that I wonder if we might get, because we hear lots of questions about the trial from the different 18 sites, and we've kind of, really chewed over some of the thornier issues on this. So we have got answers to some of them. So people ask us, what do you mean by lower limb immobilization and rigid immobilization? And this is what NICE defines lower limb immobilization as. So it's quite soft and it's quite broad. Now we've worked with the designers of the TripCast score to try and identify a nice picture of the different types of immobilization that we're using in the UK, and how many points they get you on TripCast, and what kind of category we think they fit into. So if you've ever wondered what lower limb immobilization means and what different braces score, then get involved in our trial and we'll give you a foolproof guide. So that's a really nice question that we've hopefully addressed and tackled. Some people ask us why we've chosen a TripCast score of 6 or above to define what we think is high or low risk. And that's a really interesting question that I talk about at length. But the easiest way to summarize that, I suppose, is to present this table from the original publication of the TripCast score. So the authors have essentially presented here what the sensitivity of a TripCast score is by cutoff. And they selected 7, thinking that was the best trade-off of sensitivity and specificity. But what they are suggesting with that cutoff is that they're willing to miss a quarter of the VTE events that will occur in this patient group. And using our cost effectiveness and decision analysis modeling work from earlier, we just felt that was too high a proportion, given the likelihood of this intervention being effective when you give it to a broad population, and the likelihood of it being cost effective by NICE standards, even if you give it to everyone. So we've increased the safety margin here for VTE prevention by using a slightly lower cutoff, where we think the sensitivity leans slightly more towards 90%, and the specificity and the negative predictive value is still acceptable by modern standards. What about blood tests for people started on low molecular weight heparin or started on a DOAC for this indication? Well, we think it probably is good practice to ensure that there has been a baseline measure of the platelet count and renal function and hepatic function in anyone starting prophylactic dose anticoagulation. But what we're increasingly finding within the lifespan of the trial is that sites are using, as per their local policy, blood results from the recent 6 weeks or the recent 3 months or the recent 6 months in some circumstances, providing there's been no changes in medical or no changes in their clinical situation since those blood tests were taken. And that seems to be safe. We're not having reports of excess bleeding or challenges using that approach. And within the context of the trial, we don't mandate any blood testing at all. We just ask people to follow their usual care pathways. But seeing their usual care pathways is interesting, and talking about them is interesting. And what we're also fairly clear on through the lifespan of the trial and using this guidance from the British Committee for Standards Haematology is that no one is doing repeated blood tests on these patients to look at how their platelet counts trend and track, because they're a relatively low risk population, as we've already talked about, and they have a low risk of complication. And then we've talked about aspirin, as you mentioned previously, and as it's increasingly muted in VT prevention circles. I know I'm coming to time, so I don't want to talk about this in detail, but people ask us why we didn't select aspirin within this trial. The short answer to that, again, is because the NIHR didn't commission that question. The long answer to that is that although people are increasingly looking at aspirin, they're looking at aspirin in trials like this, which was a very large study, a well-conducted study in the US that looked at aspirin, but with a primary outcome of mortality. And we're not necessarily sure that that's the right outcome for trials of thromboprophylaxis in lower limb immobilization, given we expect that to be negligible in patients who are briefed about the risk of VTE and are asked to return and get treated and diagnosed promptly. And in trials like this, like Prevent Clots, what you actually see in the secondary outcomes is that there is a statistically significant increase in the rate of VT with aspirin use when compared to low molecular heparin. And we think that's very important for reasons that I'm sure we don't need to go into here. That's all I wanted to get across from my slides. Very happy to take questions. Thank you for your attention.
Well, thank you very much, Dan. You've provoked some more questions, so I'll read them out to you.
Excellent.
And actually they are thought-provoking. Here we go. First one. 2 areas I have found quite poorly done is the initial consultation and decision to give thromboprophylaxis doesn't get communicated to the GP and so often gets stopped prematurely, or review at orthopedic clinic focuses so much on the limb, the VT risk is not reassessed and continued stroke stopped where appropriate. Is this something that you anticipate affecting results?
That's a really good question, and it has come up several times already. And from a researcher perspective, I suppose I would answer that by saying this is a pragmatic trial. So we are ensuring that we collect that data first and foremost, because I think lots of us have anecdotal concerns about compliance with therapy or about premature cessation here, but we don't really have any information on whether that's true or not. So this trial will collect weekly surveys from patients and we'll ask them, how are you still taking your medication? Have you stopped for any particular reason? Did your surgeon tell you to stop? Did they tell you to change, et cetera, et cetera? And that'll be a really nice overview of what's actually happening within the trial itself. The other interesting thing that I think we will have to look at carefully is the difference there about continuation based on low molecular weight heparin or DOAC being prescribed. So what we're finding is that sites engaged with the trial who are randomizing to DOAC are more inclined to prescribe a longer course up front because they think it's easier for patients to just give them a box of 6 weeks of tablets and say, you can stop these when you come out of your boots, but here's enough just in case. Whereas people don't really want to give 6 weeks worth of syringes because that's a big bag of syringes and it's quite intimidating. So they often give 2 weeks and they rely on the orthopedic clinic to then extend the prescription and follow things up, just as you're saying. So there's a fallibility there. And what we might find is that, tablets have advantages that we never perceived by just being easier to prescribe up front and being easier for patients to take and therefore encouraging compliance. But what we're trying not to do in the trial is steer that in any different direction. We're saying to sites, the study randomizes you to one or the other, and then we would like you to follow your usual routine for prescribing. And so we will see what happens. But as an investigator at my site, I've been contacted multiple times by patients saying, I'm not sure if orthopedics wanted me to continue this medication. They didn't say anything in my clinic. What do you think I should do? And that's an advantage to being involved in research, isn't it? They haven't got me as a backup to get involved and help them out.
Okay. There's a question from Bex Walsh. Thanks, Dan. Any thoughts on the use of the TripCast score in elective foot and ankle surgery with LLI? We have previously used a single risk assessment tool developed locally for all LLI. We introduced TripCast very recently for trauma patients, but now wondering if we should be using it for the elective population too.
Yeah, that's a good question. The authors of TripCast have also created a TripPlasty score, which I think looks at hip and knee replacements. I'm not sure it covers elective foot and ankle surgery. and we don't use TripCast outside of acute injury. So I think it would be a slight extrapolation, if I'm honest, Bex. Would it be better than a locally derived tool that's not been derived or validated or studied? That's anyone's guess, I think, isn't it? I know there have been some recent guidelines created on foot and ankle surgery and prophylaxis, and I know lots of sites are starting to follow those. I can't quite remember the society, Xavier might know, that published those.
It was BOFAS, that British
Yeah.
Foot and Ankle Society.
Yeah, so I think you're probably safer sitting with a published guideline than you are taking a score that was designed for one population and extrapolating it to a different population personally. But I'd be interested to see what others think.